Thank you, Dr. Rohit sir. Thank you, AIOS, for giving me this opportunity. I'll be talking in brief about the decision making in strabismus surgery. So we have already discussed the prerequisites before surgical planning: the good refraction, proper glasses, assessment of visual acuity, treatment of amblyopia, assessment of strabismus, history, the sensory status, and the motor status. So let us think about the planning of surgeries. So I'll be just talking about the basics. So we basically talk about two kinds of principles in the surgery, that is the weakening and the strengthening. And we have to understand that there is no true weakening or true strengthening of muscles. It is just the alteration of the length tension curve. Because true weakening will cause limitation of rotation, and true strengthening is actually increasing the muscle power, which we don't do. So various common procedures for the recti, we talk about recti here, is recessions and the Farden. Lesser known are the marginal myotomy, myectomy, and the free tenectomies. The strengthening procedures are resection and tuck or plication. The lesser known are the advancement and cinching. So this table summarizes the maxima and minimum of all the recti muscles from their point of insertion. So if you go beyond maximum and minimum, you will have some undesirable results in terms of limitation of excursion or removing of the muscle tissue rather than the tendon. Now, a few points should be borne in mind before you plan surgery. That bilateral recessions should be planned under GA, because if at all they cause any lid or globe changes, they cause equal changes. Also, the recession is reversible. We are not losing any tissue. Recession resections, if they are planned together, they give more effect per millimeter muscle of surgery, and it should always be kept in mind that no more than 2 recti per sitting or no more than 3 recti per lifetime should be operated on the same eye. Now, there can be widening and narrowing of the palpebral aperture with large recessions and large resections, which can cause widening and narrowing. Ptosis or lid retractions with the vertical muscle surgery, whether it is inferior rectus or superior rectus. So whenever we plan a lateral rectus surgery, make sure that the inferior oblique is not included, as it has been shown that in up to 1/3 of cases, inferior oblique fibers can be included in the surgery. If you're planning for an MR surgery, be careful while passing the sutures, especially when the muscle is tight. It is prone to pitting and being lost in the orbit. When you plan for inferior rectus surgery, there's a direct and proportional effect on the lid position of the lower lid. So do not go beyond 5 millimeters. Also try and do a good dissection of the capsulopalpebral fascia, which is 5 millimeters behind the insertion. For superior rectus surgery, severe the insertions between the LPS and superior rectus, otherwise they can cause lid retractions, more so when you are doing a larger surgery, specifically for DVDs. Now we talk about surgical dosage, because that is what is more important. Recession is a stronger surgery than resection, and medial recti tend to be more strong muscles than lateral recti. So medial rectus can give up to 3 to 4 prism diopters per millimeters of surgery, as compared to lateral rectus, which can only give you 2 to 3 prism diopters. Larger deviations tend to respond more. Younger patients tend to respond more as compared to elders. Axial lens, they have an inverse correlation with the dose response in the esotropia, but not in the exotropia. Then there are certain patient factors and surgeon factors which are to be considered. Now look at this patient. So we have a patient of esotropia having a 30 prism diopters of ESO without glasses and 50 with the glasses. So this is a case of partially accommodative esotropia, and we are going to correct only the deviation which is with glasses. We check for 9 gazes. There is no A or V pattern, no oblique overactions. So we just plan for one MR, that is right medial rectus recession by 5 millimeters, and we get a good result. Another case here, the case of divergent squint. There are no AV pattern, no oblique overactions, and the patient has a deviation which is equal for distance and near around 45 prism diopters. Now, how do we plan this? So we have to correct 45 prism diopters. So we plan for LR recession by 8.5 and MR resection for 6 millimeters. How do we reach to this figure? We have already discussed that LR can give you about approximately 2 millimeters 2 prism diopters per millimeter, and MR gives you around 3 prism diopters per millimeter. So a total of 35 prism diopters can be done with the MR and LR surgery alone. But when we do a combination of R and R, approximately 25% more effect is there. So combining the two surgeries together will give you approximately 44 prism diopters. And then there can be some factors which could be because of the surgeon or the patient factors. There could be some variation. So this is the post-operative result. We can see the patient is pretty well aligned. Now, this is another case where we have a consecutive esotropia. Bilateral LR surgery has been done, and the patient has a 30 prism diopters of consecutive esotropia with diplopia. So looking back the records, the patient had intermittent divergent squint in the first photograph, And then this is the post-op photograph on the right side. The patient had a manifest IDS of 30 prism diopters basin and a TNO of 120 seconds of arc. So she did require a surgery because her stereo acuity was falling down. For such a surgery, we would have planned bilateral recessions of 7 millimeters because 7 into 2 will make 14 and 14 into 2 will make 28. So trying to a little bit undercorrect, or maybe 7.5 millimeters would have been done for this case. And there was no limitation of movements. But here what happens is when we do this 7, it should have given 28 prism diopters, but it gave you approximately 60 prism diopters. So this is double the surgical dosage, double the response to the surgical dosage which we had planned. So this is a consecutive esotropia, and for a normal esotropia of 30 prism diopters, I would have planned bilateral MR by 5 millimeters. But in this case, since the dose response was nearly doubled, we just planned with one MR recession of 5 millimeters, and the patient is absolutely controlled, absolutely well aligned with the esophoria of 2 to 4 prism diopters. So such calculations can only be done when the surgeon's factors are known and the patient factors are there, which are in front of you. Now, a few other considerations: if there is a distance near variation in the deviation, there are pattern deviations, oblique overcorrection, oblique overactions, DVDs, head postures, limitation of movement. We all have to include that in the decision making. So if there is a distance near variation, if there is an esotropia, recheck glasses, proper glasses to be given, bifocals. Farden can be added for non-accommodative convergence axis type of esotropia. And if there is an intermittent divergent squint, which is more for distance, LR recession is a procedure of choice. If it is more for near, MR resection can also be preferred. So this is, we have already discussed about the A and the V pattern in the previous lecture, so I'm just going to skip that. So whenever you have oblique overactions, try to do the muscle which is responsible for this A and V pattern. If it is an oblique overaction, try to operate oblique rather than displacing the recti muscles up or down. So whenever we think of shifting the muscles up and down, it is the medial rectus which is always shifted towards the apex of A or V. Do not miss the obliques. So this is a case of consecutive exo with inferior oblique overactions. The surgery was done elsewhere, so we went ahead with the inferior oblique surgery along with the horizontal components. So we can note the elevation in adduction showing you inferior oblique overactions. Another case of esotropia with A pattern with superior oblique overactions, and we can see there is depression in adduction in both the eyes, suggesting of superior oblique overactions. Now this is a case of a DVD with divergent squint. So here we see that the patient is having exotropia, which is increasing both in up and the down gazes. This is probably because of the nasal bridge, which is disrupting the fusion. There's no significant inferior oblique overactions, and the patient is having a DVD which can be assessed in this video. So we can see the DVD in the left eye, the eye goes out and up. Similarly, there is a DVD in the right eye where the eye goes up and out again. So the patient has a bilateral DVD. So what we plan here is right superior rectus recession by 7 millimeters and left superior rectus recession by 10 millimeters because of asymmetry, and left LR recessions by 5 millimeter. The exo here was 14 prism diopters, so we tend to undercorrect the exo or overcorrect the ESO in such calculations because the recessions of superior rectus is going to kind of create little bit of ESO in these patients. And this is the 7 weeks post-surgery, and this is the video after surgery where we can see the slight amount of DVD is still left, but more or less the patient is pretty well controlled. So for good outcomes, we have to look into all the factors. For paralytic squint, there is no nomogram which can be applied. Accurate measurement of deviation and sensory status is very important. Good assessment of eye movements and specific tests, if needed, should be done, like an FDT or an active force generation test in these cases. Choice of correct procedures is important because to achieve good results, we have to know what we are planning to do. Thank you.
Thank you.